Welcome all. Good evening. Whenever I hear the name of Soundari, the thing which I remember is the buck stops here. All the bucks from all the branches, they go, and the final stops gap is Dr. Soundari. And she's been with the Agarwal group for almost like 18 years. So I introduced her to new doctors that she is born and brought up here. And she is a very well-known name in the group and also outside in the ophthalmology fraternity, and also a face courtesy to all the seasonal printing of about seasonal diseases in all the vernaculars and TV shows and rest of the media show. I would say she is the one point contact for all our clinical diagnostic dilemmas, challenges, and queries. And her enthusiasm is very contagious, too energetic. She is very quick to respond. You can call her at any time. So there is no hesitation in spite of she juggling lot of roles. Whenever it is like she has I have known her as an excellent clinician. Now, apart from that, she's proving to be an excellent administrator also, being a RMD and faculty of DNB and fellowships, and she's also in charge of the quality control. So welcome, Dr. Soundari. Dr. Preetha, she's been my colleague for the last 8 years from Porur, and she has spent almost like 14 years here. She's an excellent clinician, an all-rounder, I would say, and a very kind person. She's a keen learner, well known for her punctuality, discipline, and a straightforward, a very good teacher. Especially, I've seen her taking classes for our paramedical staff and optometrists. She can teach really complicated principles and other things in a very, very simple manner and easy to register and follow manner. And she has had her training in UK also, wherein she had an opportunity to learn about neuro-ophthalmology, and she takes care of everything. She had played a great role in as being a part of education, R&D committee, and other things. So welcome, Dr. Preetha, and we'll go ahead with the thing.
Thank you, Saraswathy, for the lovely introduction. And I would like to thank the Education Committee for giving me the opportunity to present in the CME. So today's topic is going to be slightly away from the routine surgical topics. So today what we are going to showcase here is basically she has given a good name, Peek into the Pupil. So we are going to be talking about the pupil. Why pupil is important? Because most of the time when I get the patients referred to me, most of the time it would have been written, please check the pupil next visit. So why do we do that? Why do we need to call the patient the next visit? So the pupil should be part of the examination of every case. It gives us a lot of clue, lot of idea into what is happening for the patient and how to deal with the patient. What are the investigations we need to do for this patient? All that can be looked at it by just looking at the pupil. So pupil, we might think, what is there? It's just a small thing, but it gives you a lot of clue. So looking into the pupil is very, very important whenever we are doing an examination for any patient. Let's look at the pupil. So what is pupil? Pupil is a small aperture in the center of the iris. So this pupil is supplied by the sphincter pupillae and the dilator pupillae. So what does the sphincter pupillae do? The pupil gets constricted whenever you're looking at a bright light. The function of the sphincter pupillae is to constrict the pupil, which is supplied by the parasympathetic nervous system. And whenever you're frightened or when you're in the dark, so basically the pupil dilates. So this dilation happens by the sympathetic stimulation. So what is the normal size of the pupil? If you assume the normal size of the pupil, it's around 2 to 4 in case of a photopic condition. And in scotopic condition, it go up to 4 to 8 millimeters also for some people. So what is the light reflex? This is one of the important things which we actually look at whenever we are seeing a patient. So when you throw a light onto the pupil, you look at the pupillary constriction. This pupillary constriction is a very important finding whenever you're looking at the pupil. So when you throw a light, the pupil constricts. That is the direct light reflex. When you're throwing a light onto the right eye and when you observe the left eye pupillary reaction, you call it as a consensual pupillary reflex. So what is the pathway of the parasympathetic light reflex? So whenever the light enters the eye, it stimulates the photoreceptors, and the impulses are passed through the optic nerve. Along the optic nerve, it passes through, and at the chiasma, there is crossing of the fibers. So the nasal fibers cross over to the opposite side optic tract, and the temporal fibers pass on to the same side optic tract. And from the optic tract, it passes through, and before it enters the lateral geniculate body, it emerges through the superior brachium to enter the pretectal nucleus. So, this is the pretectal nucleus. Here, the fibers pass from the pretectal nucleus to the Edinger-Westphal nucleus. These fibers are called as the internuchal fibers. There is crossing of the fibers at the internuchal plane also. So there is double crossing, one over the optic chiasma and other over the internuchal fibers. So from the internuchal fibers, actually, it passes on to the Edinger-Westphal nucleus. And from the Edinger-Westphal nucleus, which is part of the third nerve, it passes through the inferior division of the third nerve to the inferior oblique and gets laid at the ciliary ganglion. So once it gets laid at the ciliary ganglion, through the short ciliary nerves, it supplies the sphincter pupillae and causes a pupillary constriction. So if you take any lighting condition, so if you look at the right side, you might have a light. But at the same time, if you look at the pupils are always of equal size. Why this is of equal size is basically because the optic chiasma and crossing of fibers at the optic chiasma and the internuchal fibers make sure that even if the one eye is getting stimulated by the light, the other eye also reacts to it. So that's why the pupil size is the same, whatever may be the lighting condition. So let's look at what is anisocoria. So anisocoria, basically when there is a difference in the size of the pupil. So whenever there is a difference in the size of the pupil between the right and the left eye, we call it as an anisocoria. It could be a physiological anisocoria or could be a pathological anisocoria. So physiological anisocoria is when there is a difference in the pupil size, but doesn't get exaggerated when you put them on a bright light or in a dim light. The amount of difference is going to remain the same whether they are exposed to a bright light or whether they are exposed to the dim light. So that is a physiological anisocoria. 20% of the normal population can have physiological anisocoria. So what is pathological anisocoria? So pathological anisocoria is basically you have a difference in the size of the pupil. So one eye assume that the pupil size is 2 millimeter, the other eye is around 4 millimeter. So then you call it as a pathological anisocoria. And this pathological anisocoria, how will you know which eye is the abnormal eye? Whether the small pupil is the abnormal eye or whether it's the large pupil is the abnormal eye? How can we differentiate that? So to differentiate, what we need to do is put them on a bright light and put them in the dim light. So when you put them on a bright light, what has to happen? With the light getting exposed to the eye, the pupil has to constrict. If the pupil doesn't constrict, then the dilated pupil is the abnormal pupil. So you find out that the dilated pupil is the abnormal pupil in a bright light. What happens in the dim light? Normally in a dim light, the pupil undergoes a dilation. So if the dilation doesn't happen in dim light, then we know that the smaller pupil is the abnormal pupil. So causes for anisocoria, if you look at it, for the dilated pupil, so amaurotic pupil, you have Ad's pupil, traumatic mydriasis, you have third nerve palsy in which the pupillary involvement can happen, and pharmacologically dilated pupil. In case of constricted pupil, actually you can list it out as Horner's syndrome, Argyll-Robertson pupil, and pharmacologically constricted pupil. So what is afferent pupillary defect or amaurotic pupil is basically when there is an optic nerve pathology, when completely the optic nerve is involved. That eye basically doesn't have a vision, and at the same time, the pupillary light reflex is absent. So when you look at both the eyes, both the eyes pupil might appear normal, but when you show the light reflex onto the abnormal eye, the pupil will undergo a dilation instead of constriction. That is an amaurotic pupil. So when the partially optic nerve is involved, then we call it as the relative afferent pupillary defect, which can be made out by using a swinging flashlight test. So this is a swinging flashlight test. So if you look at it, basically you have to show the light onto the right eye and move on to the left eye quickly within 3 to 5 seconds to the other eye and keep looking at the pupil. So what is happening in this patient, the right eye pupil is constricting very well, and the left eye, you can see it's initially constricting and then it's escaping. So this is a case of a left RAPD. So RAPD can be made out by using a swinging flashlight test. So this is another patient in which we can see the pupil. So the constriction of the left eye pupil, you can see the left eye constricting very well. And you look at the right eye, the pupil is undergoing a dilatation whenever you're showing the light. So this is a case of a right side RAPD. So assume, can we have a bilateral RAPD? There is no terminology called it is called as the bilateral RAPD. So either it can be unilateral or it can never be bilateral. There should be a relative difference. Assume when both eye optic nerve is involved, as in a case of a thyroid eye disease, how will you find out whether the pupillary optic nerve is involved or not by the pupil? Then you have the pupil cycle time. So the pupil cycle time, basically what you need to do is make a thin slit of light, either horizontally or vertically at the edge of the pupil. So when you keep it like that, what happens as the light enters into the eye, the pupil constricts and the light is cut off. Once the light is cut off, the pupil undergoes a dilation. Then again, the light enters the eye and the pupil constricts and the light is cut off. This kind of a constriction and dilatation, you can appreciate here the constriction and the dilatation. So whenever you're putting the light, you can see the pupil constricting and dilating. So this 100 such cycles are being taken into consideration. The time taken for 100 such cycle is calculated as the pupil cycle time, which is multiplied by 10 to give us the value. So in cases of bilateral optic nerve pathology, as I told you in thyroid eye disease or where there is a bilateral optic nerve involvement, then we use the pupil cycle time. The normal is around 840 milliseconds, and abnormal is when there is a difference between the two pupils, which is more than 70 milliseconds, or if it is more than 954 milliseconds. So coming to Ades pupil. So what is an Ades pupil? So you have a large unilaterally dilated pupil. Most of the time it is unilateral. More than 80-90% of the time it can be unilateral. Sometimes bilateral Ades are also present. Absent or poor light response. So the light response is basically very, very sluggish, or it doesn't respond to the light. And near slow tonic contraction. For the near convergence, when you look at it, there is a slow tonic contraction and absence of deep tendon reflexes, which is called as a Holmes-Addis syndrome. So there is no such condition in which the light reflex is present and the near reflex is not present. So always, even if the light reflex is not there, the near reflex can be there. So near reflex, why does it happen is because the ratio of the nerve supply to the ciliary body and to the pupil is in the ratio of 30:1. So 30 nerves are acting on the ciliary body when one nerve is acting on the ciliary body, on the pupillary sphincters. So what is happening when you show the light for the light reflex, the pupil doesn't respond. While for the slow tonic contraction, the ciliary muscles contract, and that's why you get the slow tonic contraction. So this is a case of an Ades pupil. You can see the pupil being dilated. So this is a patient. So obviously you want to see what is happening on the slit lamp whenever you are suspecting an Ades pupil. So you can see nasally, here you can see the nasal side, there is loss of sphincters and there is small sphincters over here which are acting. And again, there is loss of sphincter over here. So this is how the Ades pupil will be on slit lamp examination. So what will you look for is the vermiform contraction. So when you look at the vermiform contraction, basically you look here, you look at the 6 o'clock position. You can see the muscles contracting like a worm. So those sphincters are actually working whenever the light is shown. Look at the 6 o'clock. You can see, yes, this is the vermiform contraction, a slow contraction which happened. Hope you all appreciated that when you're, yeah, that is the slow contraction which is happening at the 6 o'clock, which is very classic sign of vermiform contraction. So whenever you're suspecting an Ades, you put them on the slit lamp and look for vermiform contraction. And for confirmatory test is basically using a 0.125% pilocarpine. So 1/8 of a 1% pilocarpine is used to check whether the pupils are constricting. So instill a diluted pilocarpine onto the patient's eye, which is dilated, and wait for 10 to 15 minutes and see the patient again. When you see the patient again, actually the pupil constricts because of the denervation supersensitivity. If you're just diagnosed an EDs, the supersensitivity might not have set in. So you might not have a 0.125% pilocarpine being positive for that patient. Usually it takes a few weeks for the denervation supersensitivity to set in. So once few weeks happens, if you use a 0.125% pilocarpine, the pupil constricts. So this is before 0.125% pilocarpine. You can see the right eye pupil being smaller and the left eye pupil being larger. And after the 1.125% pilocarpine, the pupil is constricted. So in cases of third nerve palsy, this is very easy to diagnose because the patient is going to have a ptosis and the extraocular muscles are affected. And when you lift the ptosis, the eye is down and out, and the adduction is limited, the elevation is limited, and the depression is limited. So it could be either a pupil involving or a pupil sparing, depending on whether it's a medical condition or a surgical condition. In medical conditions, the pupils are not involved because the vaso nervosum is affected, while the pupillary fibers are located peripherally. These pupillary fibers receive their input blood supply from the pile plexus. So only when the pile plexus are involved or when there is a compression from outside, these pupillary fibers are getting involved. And that is basically a surgical cause whenever there is a compression from outside. So in medical, which is diabetic and hypertensive third nerve palsies, the pupils are spared. So you can see a patient here who has got a ptosis. On lifting up, you can see the eye being down and out. Abduction is fully present. Adduction is completely limited. Elevation and depression is limited. And if you look at the pupil was reacting to the light. So this was a case of a diabetic third nerve palsy. So what is a third nerve misdirection? So third nerve misdirection happens when there is a trauma or an aneurysm which has caused a third nerve palsy. When they develop the new nerve supply, then the third nerve misdirection happens. So the third nerve misdirection, you have a lid gaze dyskinesis and then pupil gaze dyskinesis. In lid gaze dyskinesis, basically you can have an inverse Jones and pseudo von Graffy sign, and pupil gaze dyskinesis is basically pseudo Argyll-Robertson pupil. So what happens when the patient tries to move the eye inwards or downwards, the pupil constricts. So this is a case of a third nerve misdirection. You can see there is a partial ptosis on the right side. And when the patient is trying to adduct, you can see the eyeball getting wider. It is inverse of the Duane's. So hence it is called as an inverse Duane's sign. And when the patient is trying to look down, you can see there is a lid lag, which is a pseudo von Graffy's. So basically it mimics a von Graffy's, so pseudo von Graffy's. So this, I was talking about a pseudo Argyll-Robertson pupil. The same patient, you look at the pupil, keep looking at the pupil. When the patient is trying to adduct, you can see the pupillary constriction happening. Just keep looking at the pupil. So when the patient tries to adduct, you can see a pupil constriction happening. And when the patient goes back to the primary position, the pupil dilates again. You can see the pupil constricting now. And basically when the patient tries to look straight, the pupil dilates. So this is a pseudo Argyll-Robertson pupil. So this is what we discussed, lid gaze dyskinesis and pupil gaze dyskinesis. So pharmacologically dilated pupil, they don't respond to 2% pilocarpine as the receptors are completely blocked. Examples are atropine, homatropine, cyclopentolate. When you use these, till the effect is gone, it doesn't respond to 2% pilocarpine. To sum it up, for dilated anisocoria, basically, if it responds to 0.125% pilocarpine, we know that there is a, if the pupil constricts because of the denervation supersensitivity, we know it's an Aedes pupil. If the pupil do not constrict with the 0.125% pilocarpine, then you use a 1 or a 2% pilocarpine. If you're using 1 or 2% pilocarpine and the pupil constricts, it's an anatomical lesion, probably a third nerve palsy, and the pupil do not constrict, the dilation was probably due to the pharmacological agent because the receptors are blocked. So sometimes you can have a traumatic mydriasis like this, where there is a sphincter tear and other evidence of trauma can be there, like a Wash's ring or subluxation of the lens, or some evidence of trauma might be there. In cases of traumatic mydriasis, usually sphincter tears, you can make it out. Here also, you can very well make out the sphincter tear over here. Like that, there will be multiple sphincter tears, which you can appreciate in case of a traumatic mydriasis. Wernicke's hemianopic pupil is very difficult to elicit. In cases of optic tract lesions, basically Wernicke's hemianopic pupil, the side which is involved is slightly dilated and the side which is not involved actually constricts well. So This is very difficult to elicit because only one very thin slit have to be made to find out whether the pupil is responding or not. So this is called as Wernicke's hemianopic pupil. Coming to the pupillary pathway, which is sympathetic. The sympathetic pathway, basically, it starts at the posterolateral part of the hypothalamus. The first order neuron starts from the hypothalamus and ends all the way down at the ciliospinal center of budge, which is C8 to T2. So from here, if there is an involvement of the first order neuron, we call it as a central hornus. From ciliospinal center of budge, actually the second order neuron starts and passes through the inferior and the middle cervical ganglion and ends at the superior cervical ganglion. So there is no relay at the inferior and the middle cervical ganglion, but gets relayed at the superior cervical ganglion. This portion between C8 to T2, which is ciliospinal center of budge, to the superior cervical ganglion is called as a second order neuron. And when this gets involved, you call it as a preganglionic lesion. From here, basically the postganglionic fibers emerge out and passes through the internal carotid artery, and the pseudomotor fibers, which supplies the sweat glands, pass through the external carotid artery. So the postganglionic fibers start from the superior cervical ganglion, passes along the internal carotid artery, through the ophthalmic division of the trigeminal nerve, through the nasociliary nerve, and through the long ciliary nerves, supplies the dilator pupillae. So as I was, So the Horner syndrome, if you look at it, as I was talking about the central Horner syndrome, mostly because of CVA or multiple sclerosis or aneurysms can give rise to first order central Horner syndrome. And preganglionic lesions usually is because of lung tumor like a Pancott's tumor or a thyroid surgery or a malignant cervical lymph node can cause a preganglionic lesion. Postganglionic like cluster headaches, migraine, aneurysm of the internal carotid artery, all these can give rise to a postganglionic Horner's. So basically, if a patient is diagnosed with a Horner's in the recent past, then it's very, very important to investigate to find out a life-threatening condition. If it has been there for a long time, basically there is no urgency, but obviously you would like to know why the Horner's is happening. Sometimes you can have a congenital Horner's also. In Horner's pupil, what happens? The pupil is meiotic because of the unopposed sympathetic activity is not there. So the parasympathetic constricts and leads on to meiosis. There is a partial ptosis and there is an inverse ptosis also. The lower lid is at a higher level. There is an apparent enophthalmos. Because of the partial ptosis and inverse ptosis, there is appearance of an enophthalmos, but basically there is no enophthalmos. There is an apparent enophthalmos. Anhidrosis, when the external fibers which supplies the pseudomotor fibers are involved, then you have an anhidrosis. And loss of ciliospinal reflex. So this pupillary dilatation happens. This loss of ciliospinal reflex is also a part of the Horner's pupil. So this patient, you can see there is a partial ptosis and the eye appears enophthalmos. And if you look at the pupil, the right eye has got a small meiotic pupil, which is very classic of Horner's syndrome. And in congenital Horner's, you have a heterochromia, because basically for melanin to be secreted, you need a sympathetic stimulation. And when the sympathetic stimulation is not there, you can have a light-colored iris and low intraocular pressure. These two can be signs of congenital Horner's. In acquired Horner's, actually, the people who are reading at 33 centimeters might keep it closer and continue to read because the parasympathetic stimulation is more than the sympathetic. So how do you differentiate the Horner's syndrome? Is by doing a cocaine test. The normal pupil will dilate when you use a 4% cocaine test. So 4% cocaine is instilled and the Horner's pupil does not dilate. Wait for 10 to 15 minutes and you can repeat the test one more time. And after next another 15 minutes also, the pupil doesn't dilate. Then we know that we are dealing with a Horner's pupil. So how does it work? It prevents the reuptake of norepinephrine. So 1% hydroxyamphetamine test. This is positive in preganglionic lesions. So the mechanism is by the release of norepinephrine. When you use a 1% hydroxyamphetamine, the preganglionic pupil dilates. So 1 in 1,000 adrenaline test, this happens in postganglionic because of the denervation supersensitivity. So the Horner syndrome and the hydroxyamphetamine test should not be done within a span of 24 hours because the mechanism is different. So it should be done after 24 hours for preganglionic lesions. And if the preganglionic doesn't work, then basically we know it is a postganglionic and use a 1 in 1000 adrenaline. So Urgell-Robertson pupil, basically both pupil are meiotic and it can be asymmetrical. Light reflex is absent, accommodation reflex is present. So what are the causes for light-near dissociation? So in cases of Urgell-Robertson pupil, in case of AD's pupil, some patients with the diabetes and alcoholism and Perinaut syndrome can have a light-near dissociation. So to sum it up, what are the pupillary abnormalities? So when the entire optic nerve is involved, as in this case, you get an amerotic pupil. When partial optic nerve is involved, you get a Marcus-Gunn pupil or relative afferent pupillary defect, RAPD. And in case of optic tract, you can get a Wernicke's hemianopic pupil. And in case of internuchal fibers getting involved, you get an Urgell-Robertson pupil. If it's because of the third nerve misdirection, then you get a pseudo Urgell-Robertson pupil. When the ciliary ganglion is involved, you get an Ad's tonic pupil. So other pupillary abnormalities like an eccentric pupil because of trauma or iatrogenic, or in cases of ICE syndrome, you can have a polychoria and basically chorectopias can be there. These are some of the abnormalities which we can encounter in pupil. Thank you.